tonight's presentation is on interprofessional collaboration. It's a journal club. I, of course, am Dr. Jennifer Bellotti-Streetman. I'm the Executive Vice President of Full Spectrum ABA. As always, if there are any questions or comments or anything that you guys want to share or discuss, definitely share vocally or put it into the chat. It's always nice to be able to learn from one another rather than just listening to me for the hour. For any analysts, there is a CEU sign-in code for tonight's presentation, which is 4580. First, we'll go through the task list and ethics code items that are relevant for tonight's training. For the BCBA task list, E2, responsibility as a professional, E3, responsibility in practice, E4, responsibility to clients and stakeholders, E5, responsibility to supervisees and trainees, H3, recommend intervention goals and strategies based on such factors as client preferences, supporting environments, risks, constraints, and social validity. And H9, collaborate with others who support and or provide services to clients. Next, the ethics code for behavior analysts. 1.07, cultural responsiveness and diversity. Behavior analysts actively engage in professional development activities to acquire knowledge and skills related to cultural responsiveness and diversity. And behavior analysts also evaluate biases of their supervisees and trainees, as well as their supervisees and trainees' ability to address the needs of individuals with diverse needs and backgrounds. 1.08, non-discrimination. Behavior analysts do not discriminate against others. They behave toward others in an equitable and inclusive manner, regardless of age, disability, ethnicity, gender expression, identity, immigration status, marital relationship status, national origin, race, religion, sexual orientation, socioeconomic status, and or any other basis prescribed by law. 1.09, non-harassment. Behavior analysts do not engage in behavior that is harassing or hostile toward others. 1.10, awareness of personal biases or challenges. Behavior analysts maintain awareness that their personal biases or challenges may interfere with the effectiveness of their professional work. Behavior analysts take appropriate steps to resolve interference, ensure that their professional work is not compromised, and document all actions taken in this circumstance and the eventual outcome. 2.08, communicating about services. Behavior analysts use understandable language in and ensure comprehension of all communications with clients, stakeholders, supervisees, trainees, and research participants. Before providing services, they clearly describe the scope of services and specify the conditions under which services will end. They explain all assessment and behavior change intervention procedures before implementing them and explain assessment and intervention results when they are available. They provide an accurate and current set of their credentials and a description of their area of competence upon request. 2.09, involving clients and stakeholders. Behavior analysts make appropriate efforts to involve clients and relevant stakeholders throughout the service relationship, including selecting goals, selecting and designing assessments and behavior change interventions, and conducting continual progress monitoring. 2.10, collaborating with colleagues. Behavior analysts collaborate with colleagues from their own and other professions in the best interest of clients and stakeholders. Behavior analysts address conflicts by compromising when possible and always prioritizing the best interest of the client. Behavior analysts document all actions taken in these circumstances and their eventual outcomes. 3.02, identifying stakeholders. Behavior analysts identify stakeholders when providing services. When multiple stakeholders are involved, the behavior analyst identifies their relative obligations to each stakeholder. They document and communicate those obligations to stakeholders at the outset of the professional relationship. And 3.06, consulting with other providers. Behavior analysts arrange for appropriate consultation with and referrals to other providers in the best interests of their client, with appropriate informed consent and in compliance with applicable requirements. Next, the RBT task list. F2, respond appropriately to feedback and maintain or improve performance accordingly. F3, communicate with stakeholders as authorized. F4, maintain professional boundaries. And F5, maintain client dignity. And now the RBT ethics code. 1.07, RBTs work directly with their supervisor to ensure that they are culturally responsive in their work. They actively work to evaluate their own biases and ability to work with individuals with diverse needs and backgrounds, and obtain any needed training in these areas under the direction of their supervisor. 1.08, RBTs do not harass or discriminate against others. They behave toward others in an equitable and inclusive manner, regardless of age, disability, ethnicity, gender expression, identity, immigration status, marital relationship status, national origin, race, religion, sexual orientation, socioeconomic status, or any other basis prescribed by law. And lastly, 1.09, RBTs are aware that their personal biases or challenges may impact their ability to effectively carry out their behavior technician services. If their biases or challenges may impact services, they take steps to resolve the issue, and they document these actions. Now we'll review the CASP guidelines. So CASP is the Council of Autism Service Providers, and these are the Applied Behavior Analysis Practice Guidelines for the treatment of autism spectrum disorder. So guidance for healthcare funders, regulatory bodies, service providers, and consumers. It's the third edition, which just came out this year. If anyone needs this document or has any questions about it, definitely let me know, and I'm happy to get it to you and discuss. So in relation to collaboration with other professionals, CASP provides the following guidelines. So periodic assessments from other professionals may help guide treatment or assess progress. Examples of assessments from other professionals include assessment of general cognitive functioning, speech and language skills, academic performance, specific learning disabilities, dental health, and medical status, including co-occurring conditions. Behavior analysts can use this information to understand a patient's strengths and challenges, identify potential treatment targets, and guide initial treatment plan development. Consultation with medical and mental health providers on the effects of known co-occurring conditions may be appropriate when developing treatment goals and behavioral intervention procedures. In addition, the behavior analyst should collaborate with any prescribing providers when an individual takes medications that are likely to impact or affect their behavior. The purpose of this collaboration should be to understand the rationale for the use of the medication, how it might impact learning new skills or recalling previously learned skills, and any other possible side effects. Generally, collaboration between behavior analysts and physicians can result in reduced reliance on the pharmaceutical intervention or polypharmacy. So, for example, medical staff for a patient with a seizure disorder can provide information regarding seizure antecedents, patient care and safety during events, as well as timelines for the cognitive and behavioral after effects of those seizures. As another example, a patient taking a psychotropic medication may require regular monitoring by behavioral staff for known side effects of that medication, with the data being provided to the prescribing medical professional. Behavior analysts refer to professionals from other disciplines in cases where patient conditions are beyond their training and competence, or where coordination of care with such professionals is appropriate. Examples include, but are not limited to, suspected medical conditions or psychological concerns, such as a seizure disorder, anxiety disorders, or mood disorders. And in these situations, it's typically necessary to continue to use ABA to ameliorate ASD symptoms and any behaviors that we're seeing. And then also we'll collaborate with professionals when we are developing treatment goals. And so patient treatment goals or client treatment goals typically are best achieved by coordinating the involvement of different individuals supporting that delivery of care. So these individuals include members of the clinical and direct line staff, so ABA staff, looking at RBTs, BCABAs, BCBAs. Direct line staff would be like the RBT, professionals from other disciplines, parents, siblings, caregivers, teachers, and the clients themselves. Together, this group of individuals forms the community where behavior change occurs and can be maintained and generalized. Then each group and individual supports patient care in different ways. As such, the behavior analyst engages each group in different methods. In some cases, the engagement involves collaboration, support, and training. And when addressing coordination of care, communication is usually the primary goal to avoid gaps in patient needs and any duplication of services. And so for us, we're always coordinating care. If there is a previous ABA company who worked with a client, previous analyst, we're looking at the plan when we develop our plan. We're also working with speech, OT, PT, any related service providers. We should be getting any plans that they are working on, any reports that they have. We're looking at the client's IEP, of course. We are getting the medication information, and we're coordinating as appropriate with medical doctors as well. And before we develop an intervention in ABA, and before we address a behavior, we're always ruling out medical needs first and any medical causes. And so we should always be engaging in coordination of care and collaboration across disciplines. So that's just some background information before we get into the journal article that we'll be discussing tonight, which is the ethical obligations, barriers, and solutions for interprofessional collaboration in the treatment of autistic individuals. Where we're working in the client's natural environment, RBTs should be engaging in interprofessional collaboration, especially with teachers, paraprofessionals, any administrators, of course, the caregivers. You're potentially helping at OT, PT, speech appointments, addressing behavior and helping them. The BCBA always is, especially when we're developing treatment plans, but RBTs are as well. And so it's really great to see that. So I thought this article had some really great suggestions, and so we'll go through those. If anyone else has additional suggestions on interprofessional collaboration, how to be effective, and anything that you guys have done that you have found to be really successful, it would be great to share. So in their introduction, they discussed how collaboration is essential in delivering ethical and effective behavior analytic treatment and maximizing client outcomes. Collaboration may include working with speech and language pathologists, psychologists, mental health counselors, occupational therapists, physical therapists, special education teachers, behavior analysts, physicians, nutritionists, social workers, and nurses. Interprofessional collaboration was defined by the authors as the collaboration among the various professionals who practice any of the disciplines that provide services to autistic individuals. Effective collaboration with other service providers as part of a treatment team requires that team members first clearly define collaboration regarding how the team can best meet the needs of the client. So RBTs should be referring to their analysts to see anything that they might have learned about the different team members, and any strengths and limitations, any preferred areas for like communication, for feedback. The same way that we have different preferences for feedback, other people as part of the treatment team might as well. They might prefer email communication or written communication as compared to vocal or in person. And so we want to gather as much information as we possibly can about the different team members. A trusting working relationship between two or more equal participants involved in shared thinking, shared planning, and shared creation of integrated instruction. And so this piece is important too, because we want the professionals who we are going to be collaborating with to trust us, and we want to always view everyone who we're interacting with as equals. Elements of collaboration often include the joint development of a common set of client-centered goals, a shared responsibility of achieving these goals, the flexibility to compromise and accept new ideas, a readiness to listen, a reflective evaluation of the collaborative process, a willingness to accept feedback, and a non-judgmental use of each team member's expertise as equals to meet these goals. And so we're always putting the client's needs first. We're remaining flexible so that we can accept new ideas. We're listening and we're reflecting and we're accepting that feedback too. And so it's easier to do that when we view one another as equals and we respect everyone who is working with the client. That way, we're more likely to hear what they say. And it's always good to reflect back and even to rephrase and repeat back what they're saying if you don't understand something. That way you're certain that you have really good understanding. And people appreciate that too. It shows that you care. The purpose of collaboration is that each team member benefits from these interactions, and ultimately the client benefits from a higher quality of care provided by the combined expertise of the team members. Participants are equals within collaboration, and all members receive mutual benefit toward meeting goals with a common client. Some ethical obligations in preparing for collaboration. Behavior analysts must be familiar with all relevant ethics codes that correspond to collaboration. And so we discussed those in the first couple slides of the training. And you should always be fully aware of our ethics codes. That way you know the guidelines that you're following out in the field. Behavior analysts must examine their competence in collaborating with other professionals, so that if you don't feel fully competent collaborating with another professional as a BCBA or as an RBT or BCABA, you can go and you can seek out feedback and additional resources so that you can develop that competence. Behavior analysts ensure their competence by being aware of and remaining within their professional scope of practice, and by frequently examining the boundaries of their competence. So these are some ways on how you can develop competence with collaboration. So first is coursework. So you can learn about and learn to appreciate other professional perspectives through taking courses. And a lot of times these courses will include reviewing journal articles like this one, applied projects where maybe you're instructed to interview someone from another profession. some fluency flashcards like SAFMEDs, looking at like terminology. What is some, how are we really defining and phrasing a similar concept? Could be an example. The second way is professional development. So reading relevant literature, attending conferences and conventions, and sometimes conferences and conventions for another field, for maybe like SLP or OT, for example, or an APA conference. Participating in workshops and other training opportunities, obtaining additional coursework, receiving coaching, consultation, supervision, or mentorship, and maintaining appropriate professional credentials. And so as part of the BACB guidelines, new supervisors are required to have monthly consultation with a supervisor, a BCBA, who has been in the field longer than they have. And an area that you can work on if you are in that situation is coordinating care and collaborating, communicating with other professionals. That's an area that I've provided mentorship and guidance in as well, based on my background. And then that supervision and consultation again, and cross-training is the fourth way. And so they had suggested understanding how other professionals make decisions and research underlying the research underlying these interventions, so including ethics codes. So if there is a specific intervention that an individual might use when working with a client who has mental health disorder, depression as an example, researching to see why they would choose to use that intervention and developing that level of understanding so that you're coming at it from an intervention perspective from the behavior analytic lens, and then they're coming with the intervention from a psychological lens. And so how do we meet, and what are the benefits of each? That'll help you to have a deeper understanding. Addressing misconceptions and practice translating behavioral language, because we never want to use our technical language with someone who is not going to understand that language. And so Colin said that with collaborating, it is important that in terms of interventions we perform, that they all be empirically validated. So seeing other practitioners as equal doesn't mean that we cut corners around our therapeutic service delivery. If other types of practitioners make suggestions regarding care of our autistic clients, we will only implement suggested interventions that are empirically supported. Yes, we only are able to implement interventions that are research-based, evidence-based, and are behavior analytic. And for an RBT, that's written into the behavior plan that's approved by insurance, by the funder. And so it's good for us to understand the interventions that another provider is using and to communicate with them as equals, because we are all human and we all have our own education and background and experience, but we are not going to implement an intervention that is not behavior analytic. We just need to show respect for the individuals who are implementing other interventions. Identifying the barriers to collaboration, so organizational constraints such as caseload size and lack of availability of other professionals. Limited communication skills is a barrier, limited time, fear of opposition and confrontation, and the need for recognition of the values of one's work. Practicing with humility. Behavior analysts so the authors had discussed that behavior analysts have a marketing problem sometimes, and that their contributions to research are largely marginalized due to behavior analysts' deliberate efforts to distance themselves from mainstream psychology. And so this is a behavior analytic article. And so the authors are within the field of behavior analysis. And this is something that they have identified in the field of ABA as being an issue. And this is an issue that we've encountered before too, not us as individuals, but as in the field, where the technical jargon that behavior analysts use sometimes, as well as sometimes behavior analysts will have a view that they're kind of like the best in the room, and that's where that like equality is very important. And we want to make sure that we are practicing with humility. Behavior analysts sometimes become aversive to other professionals when disseminating ABA evidence-based practices and looking at that terminology. There's a historical trend to reject non-behavioral interventions. And to Colin's point, yes, we should be rejecting non-behavioral interventions for us to be implementing with our clients. Absolutely. However, we should not openly reject an intervention that an SLP or an OT or a PT is finding success with the client, because they are approaching that client's care from a different perspective, different experience, different education. And so we all are working and should be working in the best interest of that client with our own backgrounds and areas of expertise. Here are so how to implement solutions for barriers to collaboration. So some proactive strategies, and then next we'll go over reactive strategies. So proactive strategies. Conflicts among a collaborative team may be resolved by referring to the client's or their legal guardian's treatment goals. So we want to be communicating with the client and with their family to see what treatment goals are important for them. That way we're targeting that social significance, of course, and we're getting consent and assent. We want to foster jargon-free communication, so it is absolutely acceptable and encouraged to use behavior analytic technical language with one another, and also at conferences, in school, to know that language, of course, but we want to modify our language to match the listener. We want them to understand what we're saying to them. We also want to use mutually acceptable and understandable terminology. We want to develop a collaborative structure in which frequent interactions of team members are planned in order to foster coordination of services and to develop a formal relationship with each other as a treatment team. Regular communication must be established. So the communication should entail active listening, engaging in dialogue and reflecting upon another's point of view, transparency and understanding each other's philosophical assumptions, as well as each other's scope of practice, reframing their discussions around what they have in common as professionals, while also remembering the differences and obligations to their ethics codes and their professions. We want to have a collaborative team, and so therefore collaborative team members should perceive new ideas from another discipline's perspective as suggestions, as opposed to like being against them. We want to be able to hear new ideas in a respectful way. Develop guidelines for collaboration and a common code of ethics that everyone can operate under. And so we, of course, have our own ethical codes for the BACB. However, this is talking about having ethical guidelines for that collaboration. So when someone speaks, like an example would be when someone speaks, it is a part of our ethics code that only that one speaker is speaking, that someone else isn't interrupting them. And so when they're done speaking, then there will be opportunities for discussion and asking questions, just as an example. And so Michelle said, it's so crucial to learn how much competence other providers have, including how much knowledge they have of behavior analytics services. Absolutely. Implementing the solutions for barriers to collaboration. So here are the reactive strategies that the authors suggested. Refer to the agreed upon guidelines and ethics codes that the collaborative team developed as part of the proactive strategies to avoid conflict. Take the opportunity to use the conflict to learn about each other's professions, as well as to take advantage of learning about new ideas from other professionals. Institutional resources can be used to reach conflict resolution, whether it may be additional training, feedback on performance, referring to institutional goals, or possible incentives to collaborate. And so if you're a supervision student, a good unrestricted activity, because we know that it sometimes can be a little difficult brainstorming what those unrestricted activities could possibly be. An idea would be to have supervision on your collaboration skills with other professionals. And so having conversations or interviews with an SLP, an OT, PT, a physician, anyone, a psychologist, anyone who might be providing services for that client, or even if it's not a specific client, looking at just learning from them about specific behaviors. Because if you have a client, for example, who's engaging in aggression as an escape maintained behavior, and they also have a diagnosis of anxiety, so there's some fear-based escape there, you could speak with a psychologist and see how they might respond to a situation, of course, leaving off any identifiable information. So you don't want to give them any information about that specific client, but it could be helpful to brainstorm and practice your communication skills with a provider from another discipline. Cultivating the qualities of effective collaboration. By promoting desirable professional interactions, behavior analysts will earn trust and partnership from other professionals and help others to recognize the field of applied behavior analysis as being collaborative. The qualities that support collaboration include valuing and being respectful of professional opinions from other disciplines, being open-minded to other disciplines, valuing the unique perspectives of team members, understanding other professionals' perspectives, understanding other professionals' roles, appreciating the science behind other disciplines, proactive and regular communication, time spent together or having a shared commitment of time, shared decision-making, flexibility to compromise during disagreements and having flexibility with roles and responsibilities within the team, coordination and cooperation, having common goals, collective ownership of goals, interdependence on each other to accomplish goals and maintain treatment protocols, a sense of shared responsibility, a sense of purpose, mutual trust, and focusing on do no harm and benefiting the client during any disagreements. So we want to make sure that we are always working to, of course, not harm our clients, but also to have the greatest benefit. And so those are areas that are common across all professions, especially helping professions. And so if you keep that focus, then that should benefit you and benefit the collaboration. Evaluating the effectiveness of the collaborative team. So to evaluate the treatment package as a whole, as well as individually. So of course, we within ABA, we are always collecting data and we're monitoring progress with those data, as well as making modifications to our treatments as needed based on the data that we are collecting and evaluating. And so we will always be evaluating our treatment package and our goals and the behaviors individually. But what the authors are suggesting here is that we should also evaluate, especially if you're collaborating as part of a team, the treatment package as a whole. And so celebrate those victories. great. The client now is able to engage in listener responding and answer different questions. They are attending to the curriculum in class. They're no longer engaging in self-injurious behavior. We're working together for the best interest of that client from different perspectives and with different treatment plans, treatment packages. And so looking at progress from kind of everyone when you are working as part of that team. Seek feedback from others, including the use of a social validity assessment, and some assessments that are available to evaluate collaboration include the Index of Interdisciplinary Collaboration, Interprofessional Team Collaboration for Expanded School Mental Health, Team Process Assessment, and Standards Adherence Self-Assessment Checklist. And so I have not looked into these further. These are assessments that the authors had listed in their article. My assumption is that these are not behavior analytic assessments. However, they could be beneficial when you're evaluating that collaboration and could be worth doing a deeper dive into. And then you want to reflect on the process and remain flexible to new ideas. Does anyone have any questions or any other comments on this article that we discussed? Looking at that interprofessional collaboration. Michelle?
Hey, so I was just gonna share, there was one part about with jargon and how, so I've had times where I ran into where I accidentally used way too much jargon when with one teacher, I think it was like a week or two ago, and I'm like, okay, I gotta go a little more simple when I'm talking to them, because especially with a kind of teacher where they don't have too much of behavior, the behavior knowledge. So I've had to really break down of what the intervention looks like and how to really explain it. For example, what does first send language look like? Mm-hmm. First you do your work and then you have free time. So just even breaking down an intervention like that, because some teachers, they don't know 100% how to do that. It's really even for providers too, working with other providers, it's just, that's why I was really saying about in my message earlier in the chat box that mm-hmm. It's so important to really learn, especially in the beginning when working with other providers. I've learned in the beginning, what I try to do is while I'm pairing with them, I try to get to know how their level, even their own competence, just as the same time as we do for RBTs and everyone. It's even just for other providers too. You want to know how confident they are when working with the clients we serve.
Absolutely. And that's a great point, that even within the field of behavior analysis, you're going to have people who are stronger with technical language than others. And that's okay, because we all have different strengths. And so even if you're speaking with another analyst, or it's an RBT speaking with another RBT, or whoever, you want to make sure that you're speaking for your listener so that they can understand what you're saying. And so if you make a statement, maybe asking, did you have any questions about what I just said? Can you restate, what the intervention might look like, just so that I can get a good understanding that you understand. Making sure that when you're talking with a teacher, a paraprofessional, or an administrator, you're breaking down that technical language. I started as a paraprofessional within the field of education, but then ended up working as a school psychologist and leading IP meetings and treatment teams. And so very early in my career, I was engaging in interprofessional collaboration. And even though during that time I was working on my second master's in ABA, and I was learning the technical language, the chances of me using that technical language was so slim because I knew my audience. And so that's very important, especially when you're talking with parents, too, because we need to pair with all significant others. And so you're pairing with the parents, you're pairing with the teachers and with the paras, you're pairing with everyone who is involved in implementing the treatments and the interventions that you're putting into place. And so IOA is great practice to do with like other RBTs, with your BCBA if you're an RBT, treatment integrity data, and finding out how the person who you're collecting those data on prefer to receive that feedback, and making sure that you're not giving like too many corrective statements or areas that need to be changed without giving positive feedback, or some areas that I had learned. So for example, if you design a treatment integrity checklist to work with teachers in a school where you're working with the client, and there are all sorts of areas where the teacher needs to improve in order for them to accurately implement your interventions, it's probably not the best choice to hand them that treatment integrity checklist. Say, oh, look, this is my intervention, and these are the things you did right, and these are the things you did wrong, even though it might be a faster opportunity at the end of that class period or at the end of the day. Definitely make sure that your communication is for your audience, and that you're doing everything that you can so that your interventions are as effective as they can be, and that that client is making progress quickly and sufficiently, of course, but also ethically. And that's part of our ethical guidelines, where we need to develop competence in interprofessional collaboration, and part of the CASP guidelines too, because it is just so important that we do develop those skills while implementing evidence-based procedures that are behavior analytic, that we do develop competencies to collaborate with other professionals. Because we're not always with our client too. We're really relying on other people to implement those interventions. Any other comments or questions? I see Dewey has a comment. So while pairing with other providers or staff, it's always a good idea to assess what the best way is to effectively communicate with them using the correct language. Absolutely. And so Adriana asked, can treatment integrity checks be done from an RBT for stakeholders, teachers, parents, etc.? Yeah, absolutely. But what you should do is you should collaborate with your supervisor on the development of that treatment integrity checklist. Also, another great way to get some unrestricted hours and great practice to take the programs that you have for your client and translate them into a treatment integrity checklist. And then you definitely can show your data and give feedback to teachers and parents, but everything should be done under the guidance of your supervisor, and just have a conversation with them. This is a skill that I'm really excited about practicing. And so can you help me? And can you give me feedback and let me know like the best way and the way that you are most comfortable with me engaging in this activity? Like, help me help you. And so I do have some other journal articles that are along the same topic that we have some time left. If there aren't any other questions or comments that we can go through, we'll go through them. We won't take as much time as the last one, just because that was the article really that we were going to focus on for the journal club. But I have some other pretty good research that we can go through with the remaining time that we have. So this article is by Kirby et al. And discusses humble behaviorism. And so it touches upon 2.10, collaborating with colleagues, and 3.06, consulting with other providers. It's part of our ethics code. And they go through some different terms that are Interesting. And so disciplinary centrism is forceful dissemination, unwillingness to compromise, and poor communication with colleagues that obstructs the scalability of behavior analysis. And it's the belief that one's own discipline is far superior to others. And as a result, its practitioners are smarter and better trained. And so, of course, we do not want to engage in disciplinary centrism. Interprofessional collaboration, which we were just discussing. So collaboration between behavior analysts and healthcare workers, educators, policymakers, mental health clinicians, social workers, and so many other professionals is critical to reaching under-resourced and traditionally marginalized populations. Interprofessional collaboration must be adopted widely and reinforced within the behavior analytic community. And here they talk about culture. And so culture is the extent to which a group of individuals engage in overt and verbal behavior reflecting shared behavioral learning histories, serving to differentiate the group from other groups, and predicting how individuals within the group act in specific setting conditions. Each group of professionals, despite vast within-group variation, engage in a collection of common verbal and overt behaviors that are learned and maintained by a set of similar social and environmental conditions. Cultural reciprocity is a process of self-observation and collaborative inquiry that involves questioning one's own assumptions and forces individuals and professions to confront the contradictions between their values and their practices. And then cultural humility is a focus on the soft skills of interpersonal communication, self-reflection, collaboration, and compromise. Asking for help in solving problems is an example, and interdependence with other professions. Here the authors go over different competencies for humble behaviorism, and the sections are roles and responsibilities, teams and teamwork, communication, and values and ethics. And then here is a visual looking at the difference between disciplinary centrism and cultural humility. And so cultural humility is an ability to maintain an interpersonal stance that is open to opposing viewpoints, recognizing one can never be competent in another's culture. It's other-oriented, so you're focusing on the other person. Acknowledges that one's own beliefs, values, knowledge, and behavior are the result of the intersectionality of their experiences. And it reflects on one's own biases and avoids making assumptions about others. The steps of cultural reciprocity are to compromise, to self-reflect, to listen, and to validate. And then here are questions and some additional details for each of those sections. So self-reflect. So ways you can self-reflect include, is disciplinary centrism influencing my opinion and behavior? Am I practicing within my scope of practice? Am I honest about my scope of competence? What belief, value, or assumption is motivating my behavior? What assumptions have I made about my colleagues' knowledge and skills? Is our disagreement related to cultural differences? What do I value most and why? Does my behavior align with my values? What stereotypes am I relying on? Why do I care so much about this? What about this makes me uncomfortable? Do I think my culture is superior and why? Am I demonstrating humility or hubris? Do I think I am better than others because of my abilities? To listen, so you can ask, how do you explain that? Help me understand what you mean by. What would you recommend in this situation? Where can I read more about that? I'm still a little confused. Can you explain it again, please? Thank you for teaching me about your perspective. Oh, I totally misunderstood. Thanks for correcting me. I'm open to being persuaded. Tell me more. And let me try to summarize how I understand what you said. To validate some examples. So this is in an area in which our training differs. I appreciate you explaining it to me. That makes a lot of sense. Your contributions were vital to this solution. Thanks. Both approaches have merit. I see, you believe. You do blank very well. I haven't thought about it like that. Thank you for sharing your perspective. And so these are examples where if someone is speaking to you about an approach that differs with the way that we would target a specific skill, you can say, this is an area in which our training differs, or your contributions were vital. Both approaches have merit. And so you're not saying that you are going to adopt anything that they're doing, but you're listening to them and you're validating them and you're showing that level of respect and that you are equals as individuals and practitioners, but not, you still, of course, are implementing behavior analytic evidence-based treatments. So a difference there, of course. With some good examples. And here's compromise. So an alternative perspective is, I understand that differently. Both are good ideas. How should we decide which to choose? There is another option to consider. I'm not convinced yet, but I'm open to hearing more. Let's evaluate the evidence and make a decision together. I'm willing to compromise as long as we use progress monitoring data to evaluate the decision. I think you have changed my mind about that. So, of course, only when it's appropriate to compromise, but some examples of things that you can say, and I can send you guys the slides or drop it into the chat for you too. And the learner is always right. So having a perspective that the learner is always right, which we very much do in behavior analysis, can lead to accepting and honoring team decisions and enhance the process by which the team operates. And data-based decisions on implementation of interventions by the team. So we, of course, always want to be engaging in data-based decisions. Well, if there aren't any other comments or questions, so Michelle said, learner input is important too for clients to be involved in the process. Yep, absolutely. And that's something that we've learned from our autistic advocacy forum and group too, is how important assent is, which people and providers are not always getting. We always get consent, but not always assent. And so that's important. So the CEU sign-up code is 2837. And then here are the references. And so if there's anything here that you guys want to access, you can you can use the link, you can search for them too, or just ask me and I'm happy to give you whatever you need. All right, well, I hope this was valuable for you guys. If you have any questions about interprofessional collaboration, definitely don't hesitate to reach out. We're happy to help. All right, well, I hope you guys have a great week and let us know if you need anything. Take care.